Keisha Christensen. I'm a nurse practitioner. I have an interesting history where I worked at the Med Center for many years in kidney transplant, and then we left to move into Northeast Nebraska, so raise our kids in a smaller town setting. So I worked in pulmonary medicine there. They didn't have kidney transplant up in that area, obviously. So had a nice long experience in pulmonary medicine, learned a lot of new things that I never thought my brain could ever learn. And then we decided to move back to Omaha when the kids were all out of the house, and landed a job in thoracic surgery, so pulmonary background kind of fit. And we have taken on in thoracic surgery the smoking cessation counseling part, because we see obviously a lot of patients that need thoracic surgery for conditions related to smoking, mainly lung cancer, esophageal cancer, and obviously a lot of lung nodules and things like that we follow. So smoking cessation has kind of fallen under the thoracic surgery umbrella. So even though I had done a lot of smoking cessation counseling, or I thought I had when I worked in pulmonary, I learned so much more about it through a training course at the Mayo Clinic. So I did a Mayo Clinic training course and became tobacco certification, or tobacco cessation certified is how it goes. And so we see smoking cessation patients that are interested in quitting anyway every week in our clinic. So I probably see, oh gosh, the numbers can vary, but either return or new patients, I probably see a total of about 7 to 10 per week. So anyway, with that, we'll get going. And I understand all of you all are pharmacy technicians, is that right? So you probably have some experience with patients coming in and buying their, or getting their Chantix, Wellbutrin, nicotine patches, Nicorette gum, things like that. They probably talk to you if something's not covered well or whatever, probably have questions along the way for you. So hopefully what I share with you today will lead you to helping more patients down the road with this tough battle of nicotine addiction. So first off, cigarette smoking. So obviously we all have been around people that have smoked. I know my grandfather smoked. It was just kind of part of everyone's lives back in the day, you know, and even I think back to when I first started as a nurse, believe it or not, people could smoke in the hospital, the patients could smoke in the rooms, we were emptying ashtrays, you know, things like that. So it was just, it's quite the deal what we've learned about the health risks and the dangers of cigarette smoking over the years. So first off, it's the leading cause of preventable death in the United States. So that particular stat kind of shocked me when I heard of the fact that it seriously is the leading cause of preventable death, but we're still allowed to buy them. You know, why can anybody can just walk into the store and buy cigarettes still? It's responsible for over 7 million deaths worldwide and over 480,000 deaths in the United States annually. So again, my question, why do we still allow this, right? And then knowing that about smoking and nicotine is more addictive than any other substance out there. So there's a lot of push to help people that are addicted to drugs, heroin, meth, things like that, which needs to happen, don't get me wrong. But if you think about the fact that nicotine, you know, really is responsible, smoking is responsible for this many deaths per year, and it's more addictive than heroin or other substances, and the most difficult addiction to treat and cure people of, you know, why more efforts aren't put toward trying to, you know, put some sort of ban out there on cigarettes. So it's kind of one of these questions, you know, that keeps coming to my mind, you know, the more and more learning about it and working with patients that are affected by smoking cigarettes. And I don't mean to be judgmental when I say these things. I just get really passionate about it, I guess. So nicotine, if you think about the two components of cigarettes, nicotine is not necessarily the most harmful to their health. So we try to really get that through to patients that are trying to quit. The smoke inhalation from the tobacco is the harmful part to their health. But nicotine is the addictive part. And that's why when we help people or when we're starting on a smoking cessation plan for them, we really do need to include nicotine replacement, because that is the substance they're addicted to. And if they're not getting it, they're going to fall back and they're going to start smoking again. So I try to, emphasize to patients that nicotine itself is not the most harmful component of smoking. The carcinogens in the tobacco and then heating the smoke, inhaling that heated smoke into their lungs is what causes the health concerns. So there's people that oftentimes come into the clinic and they say, I've tried this, it didn't work. I've tried this, it didn't work. I've tried this, it didn't work. Really, the most effective treatment strategy is a combination approach. And so that's where we take people when we start prescribing medications. And statistically, the most effective treatment plan for smoking cessation is combining counseling, one-on-one. Sometimes group counseling is an effective method depending on the person, but one-on-one counseling, nicotine replacement medications to fill that nicotine addiction. And then we use Chantix or Wellbutrin. And of course, the patient has to want to quit. So patient accountability is huge, what motivates them, that sort of thing. So their individual personal motivation is key. And then I usually talk to them about how important is it right now for you to quit and how confident are you in your ability to quit. And we kind of work through our plan together that way. So that kind of takes me to where do I start with patients that come into the clinic. So first off, what brought them there? And I can tell you if somebody is pushing them in the door to come in for counseling, they're probably not ready for it. The people that tell me that they enjoy smoking, but they know it's bad for them and they have to quit. Those are the people that maybe aren't going to be super successful until, we can continue to work together and I can get them there. A lot of times we see people in our clinic because they need surgery, and some of the surgeons will not operate on a person until they quit smoking, just depending on what they're doing. Some of the surgeons also want them completely off nicotine. So that's something I have to find out is it just smoking or is it nicotine too? Because some of the intricate vascular procedures that are done in surgery, the vascular surgeons want them off nicotine as well. So anyway, what brought them here? Did a doctor suggest it? Did they want it? We do get a lot of self-referrals in the door, so that's usually the best case scenario. Sometimes they have a new lung finding that has scared them to death and they want to quit because they found out that they have new nodules, or they may have a cancer, or they may have new diagnosis of COPD or something of that nature. So anyway, I do talk to them about health benefits of quitting, why it's dangerous to their health. And there are many, many benefits to quitting other than their lungs. So oftentimes they do come in because they are having struggles with breathing, or they talk to their primary care about that and they suggest smoking cessation. There's so many heart benefits as well. Circulation improves nearly immediately after somebody quits. Oxygenation to their body improves, and their stroke risk goes down. And so I do focus on the pulmonary benefits and reducing cancer risk, but there are many other benefits to their health that they can't even appreciate yet until they quit. But then I also give them the grace of knowing that their addiction is real. And the fact that most people start smoking when they're teenagers, and the teenage brain can get addicted even quicker to any substance, including nicotine, even compared to an adult brain. So a lot of them started smoking when they were teenagers, sometimes even like grade school kids, when they said, oh yeah, I started smoking in 2nd grade, 4th grade, these types of things. But most of the time it's a teenage start, or early 20s, college, things like that. So just informing them, because many people feel when they come into the clinic a lot of shame over the fact that they've wanted to quit. I've had some people tell me that they've truly wanted to quit for the last 20 years or 30 years, and they just haven't been successful. So they feel like a failure. They feel a lot of just self-shame over that. So trying to just get them past that and just have them know you didn't fail necessarily. You haven't been in the right place to get the right treatment and counseling, and you have an addiction. Your brain is addicted to this substance called nicotine, and it's real. And the feelings that you feel when you haven't smoked in a while are also real. So kind of helping them learn that when they started smoking, their brain developed literally thousands of nicotine receptors. And when those nicotine receptors are open and empty, they haven't been filled in a while, that's where the cravings come in. That's where their withdrawal symptoms come in if they're trying to quit cold turkey. And then they just smoke, fill up the receptors. And when you smoke a cigarette, those brain receptors are filled typically within 7 to 10 seconds. So it's a very quick cause and effect when they smoke a cigarette that they get the brain receptors filled up again, or at least a start to that, and then they feel better because they get that dopamine release. So kind of trying to help people learn that when your nicotine receptors are filled up again, the reason why you're so addicted is that you release a chemical in your brain called dopamine, which is our feel-good chemical. We like how we feel when we get some dopamine release. And also kind of helping them know that that's why they smoke in response to sadness, anger, frustration. They just want to feel better, and they've learned this behavior since they were kids. So, just kind of processing through all that, and then they're like, yeah, they kind of agree with everything at that point. So they see it, they understand it, and they know that everything we're saying is true, but it's just, okay, now what? How do I get them to kind of take it to the next level and be able to be successful on their quit plan? So I usually find out how much they're smoking, when they started, have they successfully quit before? So if somebody says that they've quit and they remained quit for a year, 2 years, I call that, definitely success. So what did you do? What did you use? Did you use Chantix? Did you use nicotine receptor or nicotine replacement? How did it work? Typically, when they quit and when they relapse because of something crazy bad that happened in their life. A huge stressor, somebody in the family died, somebody got sick, and that pushed them back into smoking. So we also talk actually from day one on how are you going to kind of work through those emotions moving forward, because stress happens to everyone no matter what. So when you're quitting smoking this time, you're going to have some new stress that'll come up in your life. You're going to have people that go through something hard alongside you. But things happen. We know that that's how life is, right? So what is going to be their help at that point so that they don't go back to smoking? And then we work on a treatment plan that works for them, and they feel like they can do it and kind of give them some confidence back. So these are some of those health benefits that I emphasize. Carbon monoxide levels drop to near normal within 12 to 24 hours after quitting. So therefore, their oxygenation and circulation improve really quickly. So if we would have a carbon monoxide reader that a smoker would blow into, it would blow an abnormally elevated result compared to a non-smoker. But it's exciting for them to hear that quickly that number goes down to normal. So as soon as they quit, within a day, they don't have that elevated level anymore. And I tell them some of the big stuff like this. 2 to 3 months after quitting, their heart attack risk begins to decrease, and their lung function can begin to improve. And some people will subjectively tell me, even if they have COPD and especially asthma, that they notice better breathing. I've had some young people that didn't even realize that they were having some difficulty breathing until they quit. And then they're like, yeah, I'm at the gym and I can do so much more and it's so much easier than it was before. So some people don't even realize it until they quit. 1 year after quitting, the risk of coronary artery disease is half that of a smoker, and it continues to go down with time. So that's huge because there is a lot of heart disease out there. A lot of people have it in their family. A lot of people have it personally, and they're still smoking. So they can see some improvement in that over time or reduce their risk. I like the 5 to 15 years after quitting, the stroke risk is reduced to that of a non-smoker. So if you can tell somebody that their risk for stroke will go down, it sounds like a long time, but no one ever wants to have a stroke, so just being able to tell them that they could potentially prevent, stroke risk over time. And for women, 10 years after quitting, their bone loss and hip fracture risk due to smoking begins to reverse. So smoking can and does affect the bones. So there's many health things that people aren't even aware of. So. And then it comes to cancer. So, near and dear to our hearts because we see a lot of patients with lung cancer and thoracic surgery. Cigarette smoking is responsible for approximately 90% of lung cancer cases. So, and those are statistics, those aren't numbers that people make up. The other 10% is due to environmental factors such as exposures from various chemicals, farmers, insecticides, ammonias, and radon, which is that odorless gas that can be in the ground, and people are at higher risk if they have an enclosed basement. So the good news is 10 years after quitting, lung cancer death risk is about half that of a smoker's. And risk of other cancers such as mouth, throat, esophagus, bladder, kidney, and pancreas cancer decreases. So everybody thinks smoking lung cancer, but smoking does contribute to other cancers. And I do like people to be aware of the fact that when they quit, they actually will help the risks associated with those around them. And secondhand smokers also have an increased risk of cancer as compared to people that aren't exposed to secondhand smoke. And I like telling them that if they quit before age 50, they reduce the risk of dying over the next 15 years by half as compared to that of those who continue to smoke. So just, not necessarily to scare people, but encourage them that they're doing the right thing for themselves and their health moving forward. And I don't remember if I have this in a slide, but I do tell people too that people that have young children and like babies crawling around on the floor. So even if you keep, you're not smoking around them necessarily, but babies and toddlers and things can absorb nicotine from carpet, furniture, clothing. And if they would test a baby or young toddler nicotine levels and one of the parents smoked, they would most likely have an elevated level. So that's also something kind of like earth-shattering sometimes for people to hear, that they could definitely be affecting the health of their kids. And kids that are around secondhand smoke from a parent have a much greater tendency to have childhood asthma. So anyway, lung cancer, just to kind of give you a little bit more information on that, it is the #1 cause of cancer deaths. And the current new cases of lung cancer per year in the United States, and these were numbers from 2022 when I made these slides, but they really don't vary too much year to year, are really pretty high. Estimated deaths due to lung cancer per year are also quite high. And these numbers of lung cancer rates are significantly higher than other types of cancer. So, we hear a lot about colon cancer, breast cancer. Lung Cancer Awareness Month is in November, but I'm not sure people put together how much lung cancer affects lifespan, because 5-year survival of lung cancer is 25%. So that's why we do a lot of early detection. We try to do lung cancer screening and things as well. But you have a question?
Do you also find that lung cancer kind of has a stigma because it's like a cancer people perceive to be something?
Sometimes it does, yeah. And yeah, it can, gosh, we see so much lung cancer in our department, so I'm just a little skewed. But the thing about people that smoke and have lung cancer, we are catching lung cancers earlier because of the screening program. So there is the low-dose screening CAT scans that can be done in smokers from if they're ages 50 to 80. And if they've smoked an equivalent of 20 pack years, they are eligible for this, even if they've quit within the last 15 years. So lung cancer screening has actually helped many people that smoke. The sad thing is that our non-smokers that are still getting lung cancer aren't getting screened. So we unfortunately aren't catching them as early. So, sometimes it's just by happenstance, they'll have a chest x-ray for another reason, and then we'll catch somebody will catch their nodule and then refer them. But, so it is making progress on screening, and And yeah, I think you're right. I think there is a bit of a stigma there. There shouldn't be, you know, because honestly, when people started smoking, it was the cool thing to do. You know, everybody was doing it. It was on TV, it was on commercials, and cigarettes are still being sold. You know, we've got these things that are causing people to die, and people are still buying them, and manufacturers are still selling them. So, you know, we're kind of fighting a little bit of an uphill battle, but I think that screening program is very beneficial. On screening, that just led me right into my next slide. Sadly, only about 6% of eligible patients have lung cancer screening exams done that are eligible. And in Nebraska, our percentage is even slightly lower than that. We were just up at 5%. I do feel like it's improving, just getting the more word out, and primary care offices are more inclined to order lung cancer screening exams, but sometimes I think they hesitate because if they order it and they don't know what to do about it, you know, so just kind of any test you order, you want to know what to do about the results. So, but I do think our screening exams in Nebraska are growing, which is good. And that's just getting the word out, more people like you guys knowing about it, you know. And unfortunately, even fewer in lower socioeconomic eligible patients are getting screened. So we do need to we have some work to do here. The screening criteria, like I mentioned before, ages 50 to 80, if they've smoked a 20-pack year history or more, and even if they've quit. The thing about a screening exam is they're not supposed to have any current signs or symptoms of lung cancer. And the reason for that is the screening CAT scan is a low radiation. So if somebody actually has some symptoms, cough, shortness of breath, then the insurers want them to have a better test. So they're not supposed to come in for the screening exam with any current signs or symptoms. Okay. Any other questions about that part?
I have a question.
Yeah.
On the 2 slides back, you had a NE abbreviation. What was that?
Oh, I'm sorry, Nebraska.
Oh, okay, Nebraska.
I apologize. Yeah, Nebraska's rate and then the US rate. Okay. Nicotine addiction. Okay, so like I mentioned before, when people smoke a cigarette, smokers quickly absorb nicotine by inhaling into their lungs. It hits their blood circulation very quickly, and it goes straight to the brain. That begins within 7 to 10 seconds when you start smoking a cigarette. So quick relief when somebody smokes. I already kind of mentioned this, so I'll just sort of skim through it, that they've developed multiple thousands of nicotine receptors in their brain. When they are filled, dopamine is released. When they are empty, then the smoker gets cravings for more, okay? So they're never satisfied really completely unless you're smoking. When they're depleted, they crave their next cigarette, and then just smokers learn to crave that dopamine release feeling.
Is that true even if they substitute and they're using e-cigarettes?
That's my talk for tomorrow, but yeah, you think I'm passionate about hating cigarettes? Yeah, I hate that stuff even more, so yeah, get ready for that. Yeah, e-cigarettes usually have nicotine. So yeah, anything they're inhaling into their lungs is going to reach their bloodstream quickly and go to their brain quickly. So, but yeah, we got a whole talk about vaping and stuff.
I have a question on like chewing tobacco.
Mm-hmm.
Is that the same thing as like the effects on smoking a cigarette?
The nicotine part, yes. And the carcinogen is in the tobacco. So the difference is they're not inhaling the smoke into their lungs. So if you could say like the damage to the lung tissue maybe wouldn't be as significant as far as like causing COPD, but cancer rates, you know, definitely with head and neck, esophageal, and lung cancer are still there with chewing tobacco. And the potency of that tobacco can be pretty significant. So when I was, and we treat people that chew tobacco also for their addictions and their wanting to quit. What was crazy to me was to learn that 1 can of chewing tobacco is equivalent nicotine-wise to 4 packs of cigarettes per day. So if somebody is chewing a can a day, you have to put 4 nicotine patches on them to help them. Yeah, it's crazy.
So I know a person that used to use them little pouches.
Uh-huh.
You're supposed to tell
The-
them not give the nicotine.
Is it the Zyn pouches?
I think so.
So the Zyn pouches, what I don't care for about those is, number one, they're not FDA regulated, so you don't really know what's inside. It's supposed to be a nicotine-like substance, but it can have an equivalency to nicotine up to, even higher milligram dosage, like 6 milligram pouches, 3 milligram pouches. And I caution my patients away from those just because they might just be trading one addiction for another, because I don't really know. Like, they might be getting even more nicotine than they're getting now, It's just really hard to know. So I think, a lot of these things, their intentions are good, but I just sort of stick to what I know and what is FDA approved substance as far as like what is truly in this nicotine gum. At least I know how many milligrams is in there so that we know when you're ready to reduce. Like those Zyn pouches, I had a patient that asked me about them, and so I kind of researched them some, and they can get 6 milligram pouches, they can get, and we usually don't give a craving replacement milligram more than 4 milligrams. So when somebody smokes one cigarette, they technically only get about 4 milligrams. So, it's like, I don't really necessarily want them to get something that could be more, and then they're just trading one addiction for another, even though it's not tobacco, so less carcinogen. But if their goal is to not be addicted, I like to have something that I know for sure is dosed appropriately, if that makes sense. I mean, it's probably definitely better than chewing tobacco, but I want to know that we have a plan and an end date in mind. So when people come in and we're talking about the nicotine receptors, we're talking about their addiction, we kind of get past they feel badly about themselves and all that kind of thing, and kind of starting to feel a little better about themselves, just knowing that the addiction happened very quickly and it was out of their control at the time that they started smoking, basically. I like to know how addicted to nicotine they are. And one of the scales we use is to really find out, it's called the Fagerstrom score, and it's really focused on how quickly and how much they're smoking in the mornings. So when they sleep overnight, they're not most people aren't waking up and smoking. So when they get up in the morning, their nicotine receptors are depleted. They're ready to be filled. So if that person goes and smokes within 5 minutes, their nicotine dependence is likely a little higher, okay? And then I have more. These are kind of all the questions on the Fagerstrom that we ask. How soon after you wake up do you smoke your first cigarette? If it's within 5 minutes, I know that their nicotine dependence score is going to be probably up there. Is it hard to refrain from smoking in places where it's forbidden? So usually people will start off saying, oh, no, it's fine. But then when I ask them, well, how long can you be at a place? And they're like, well, after an hour, hour and a half, or 2 hours, I'm ready to, I kind of like excuse myself. So, then they're kind of in the middle there on how hard it is to refrain from smoking where it's forbidden. Some people say, well, I can work my 10-hour shift and not get a craving. Well, then I know that their nicotine dependence is probably not that high. It's probably just the habit of it, So it's just, this is kind of telling as far as how dependent on nicotine they are, because that helps us drive, how much nicotine replacement we need to give. Which cigarette would you hate most to give up? All the others in the day or the first one in the morning? So if they would hate that one the most, their nicotine dependence level is going to be higher. How many cigarettes per day do you smoke? That kind of gives them a score. Do you smoke more frequently during the first morning hours? In other words, do you kind of chain smoke right away? And then you kind of get, feeling better, and then you can kind of go to your normal. And do they smoke when they're so ill they can't get out of bed, like with the flu? So the higher the score, the higher their level of nicotine dependence. And then, potentially I just tell them all it means is you're going to probably need nicotine replacement longer. It doesn't mean that you're never going to be able to quit smoking, but just know that you're going to need this product longer. And that's okay, because the nicotine replacement is not addictive like cigarettes are, and we'll be able to get you off of it eventually. But it just kind of helps guide, how long I may need to treat with the 21 milligram patch and the 4 milligram gum or lozenge or that kind of just that way. I saw somebody today who actually said that she can go a 10-hour shift without smoking. So, she's kind of mostly just smoking out of habit and things, but probably not using enough gum. And so anyway, just kind of working through that. And then I don't know about you guys if you hear about this a lot, but I have just a handful of people here and there that really have trouble getting the patch to stick. I wish that it's just stuck to everybody. But some people just have some skin, whatever it is, if there's oils or maybe sometimes too dry, that they have trouble getting that patch to adhere, and then that can be kind of hard too. Then they obviously, if they have a high nicotine dependence level, they're going to need more of the extra for those cravings throughout their day. So I also, in the first visit, assess how important it is to them to quit right now. Basically what brought them there. If they rate their importance less than a 6, I would really question why they're there. Really, when the person isn't self-driven or self-motivated, it's really hard. Like, I can't want it more than they do, so like they have to have some self-motivation. And then how confident are they in their ability to quit? I have them rate these on a 0 to 10. Most people are very little confidence. Most people will rate their confidence somewhere between a 1 and a 4 or 5. Usually by the end of our visit, they're rating it a little higher, but they still kind of have that low level of confidence. So we talk about triggers. What triggers them to smoke? Why are they smoking? Why are they reaching for the cigarettes throughout the day? You can probably guess what the most common ones are. Morning coffee, after meals, when they're stressed out, when they're angry, driving. Driving's a big one. When they're socializing, and alcohol can be a big trigger. And then some people use it as a reward. They feel good, they're going to smoke. They feel sad, they're going to smoke. A lot of those emotional highs and lows. And then, like I mentioned before, have they been successful at quitting in the past? And if they have, then we work on building on whatever worked before and maybe add to their plan. So let's go to medicines, because that's kind of your guys' area of expertise. Here's another little pet peeve of mine about this. Even though smoking is directly causes nearly 500,000 deaths per year in the United States, we really only have a handful of meds to use to treat. So many illnesses, there's like 25 different meds to choose from. We get these. This is it. We get Chantix, Wellbutrin, and nicotine replacement. They are talking about the rage of the GLP-1s. They're kind of talking about these things potentially in the future being, or Wegovy being for smoking cessation off-label. So that'll be interesting if we can actually see that come to fruition, and if people will be able to afford it. Because, the affordability, getting insurance to cover it, all that kind of thing, probably will be a stumbling block, but I'm all for it. If we can have some other options, that would just be great.
I have a question for your clients that are, that travel. They may have to take international flight or something to that effect. Flight might be 4 to 6 hours or even longer than that. Do any of these meds help, or do you have to prescribe something differently usually?
Nope, this is all we got. So yeah, I mean, this is it. If they, I would encourage them to have their patch on, and then to have plenty of the lozenges or gum with them, whatever they choose, because those things work. They take a little longer, but like if somebody puts a 4 milligram lozenge in, it's not going to hit their brain in the 7 to 10 seconds, but it is going to work, and it's going to kind of ease that craving, and they'll be able to hopefully distract themselves to get it to go away. But yeah, I would say if they knew they had a long period, I would say make sure you have your patch on and make sure you don't forget your lozenges.
The scary thing about all that is also a lot of the lozenges, the gums, sometimes patches, and even Chantix may not be covered.
Oh, I know.
They end up having a long, and that's actually a stressor. We're not
Mhm.
too many of them. That
It
I really
is.
want to try, but my insurance doesn't care.
Yes, and that's where I appreciate so much the pharmacies that go that extra mile and try to find them a coupon or something, because that is so valuable. A lot of insurance companies are paying, a lot of even Medicaids and things are covering some things, but a lot of times if I order nicotine patch plus lozenge, they'll only cover one of the two. So I will enroll them in Nebraska Quit Now because they will get something for free. So Nebraska Quit Now is a statewide program. Iowa has a program too. I'm sure most states have a program. And I'll enroll them in that. And then they do have to take the calls, and there's some counseling that they'll get over the phone. And then they will, if they agree to some counseling over the phone, they'll get mailed something for free. And
Will
so
drugs be covered if they're not covered by insurance by a healthcare spending account? Like if they were to put money?
I think so, yeah.
And they have the
For sure.
OTC benefits, like you have an OTC benefit
Yeah.
card, and your FSA possibly, so there is a way around
Yeah.
it, but it's not always.
Kind of like if they were buying a vitamin. I mean, they'd be able to use their health care spending account and things like that, for sure. Let's see, what do I have next? So I'm going to talk about these things kind of individually. Chantix, I love because it works directly on the nicotine receptors to not release the dopamine. It creates less satisfaction after they smoke, reduces the want for a cigarette. It affects everybody differently. Some people that I start on Chantix, they quit very quickly. And then once they quit and we kind of feel like they're more confident, I usually just take Chantix off slowly to give them that confidence that they can do it without Chantix. But I try to have it on just the minimum amount of time that we need. Some people get kind of dependent on it and they feel like when I reduce it to once a day, they get more cravings. So if that's the case, we just continue it a little longer with nicotine replacement and see if we can't just ease them off of it. As you guys probably know, it had kind of some bad press a few years back, causing some increased black box warning, increased depression and suicidal thoughts. The company actually did a big study, which makes me feel much better about it, and I explained this to patients, that it did a large randomized trial where there were like 1,200 participants, some on Chantix, some on placebo, and depression and suicidal rates were the same. So they took the black box warning off, and so I tell people that. Now, when people have depression or anxiety, I'm not necessarily afraid to start it, but I tell them we're going to monitor you close. We're going to monitor your mood because it reduces dopamine release, and so if you have a tendency to be depressed, you could have some mood change. But I'm oftentimes just surprised by it because a lot of people tolerate it really, really well. Some have tried it in the past and they don't want to try it again because they had some side effects that they don't want again, and I appreciate that. However, sometimes I will say maybe we could start just a small dose and not go up to the 1 milligram twice a day. So sometimes I'll go with the 0.5 daily, sometimes 0.5 twice a day, and then just leave it at that and not have them go to the 1 milligram twice a day. And oftentimes, even if they had side effects with the 1 milligram, they do well on the 0.5. So we have to look at their kidney function. And that's the other really great thing about Chantix that I love. You don't have to worry about other drug-drug interactions. There really aren't any to be concerned about. Nausea, if it's taken on an empty stomach, so we make sure people take it with food. Sometimes some insomnia and dream disturbance, vivid dreams or nightmares, and then the mood changes. So I kind of said all this. One of the trainers at the Mayo Clinic, the doctor actually that was given the drug talk, he said that some circulating Chantix, some is better than none at all when you're trying to help people quit smoking. So even if they can tolerate a small dose, it's maybe worthwhile to have them on just a little touch than none at all. So, and I personally have found that in my patient population, people are able to quit much quicker when they're on Chantix and more successfully. Wellbutrin is another medication that does have an indication for smoking cessation. I kind of call it my second choice if they're not able to tolerate Chantix. I've had patients have just as many side effects on Wellbutrin as they have on Chantix. They have to look at their history. They aren't to have a history of seizure disorder or alcoholism. Wellbutrin does reduce appetite, so if somebody's already underweight, maybe wouldn't want to use it. It stimulates the brain to produce dopamine, which therefore helps reduce cravings to smoke and also helps with withdrawal symptoms. So that's where I tell people that it may come in and help them. And we dose it 150 daily for 3 days, then twice a day thereafter. And so not the XL 24-hour, just the 12-hour. And I kind of hesitate on Wellbutrin if they are on another antidepressant or mood treatment, just because I'm not exactly sure how it may interact. It cannot be prescribed if they're already on an MAOI, but almost nobody is, so that's good. I've asked for their psychology provider to okay it before I'll go ahead and start it. It's kind of my process with Wellbutrin. It can also have sleep disturbance and insomnia, so usually we tell them to take their evening dose a little earlier, and some people can have some mood fluctuation. Nicotine replacement is a must, so even if people tell me that, oh, a patch didn't work, gum didn't work, most people haven't used them together. So that's where I tell them that's what we need to do. The nicotine patch is going to give them that steady state of nicotine, where the gum or the lozenge is going to help with their cravings. And so usually I can get them kind of at least agreeable, and then we do have that, is it going to be covered issue. So, and you guys know how to instruct people on these things. The gum, they chew a few times and then they park it. So a lot of times I kind of tend to go to the lozenge, because I find sometimes with the gum, people forget and they just keep chewing it, and then they swallow it and get that saliva and it makes them kind of nauseous. So chew 4 or 5 times, park, kind of break it down and then park it, or just the lozenge. I don't know about you guys, but I've had a few patients in a row tell me that the Rugby brand of gum is horrid. I don't know if you guys have heard that. So I'm the one who's writing to the pharmacist, do not fill the Rugby brand. So I don't know how successful that is.
Here, now we know.
Yeah, you're gonna get that from me, because literally, they said that it tastes horrible and it turns into a rock. So they can't even chew it because it turns into a rock like cement. So anyway, but otherwise it's nice that there's a couple other flavor options out there, like cinnamon, fruit, and mint, of course. There is the Nicotrol nasal spray, but again, coverage is just hard. I don't see that it's very successfully prescribed, or I don't prescribe it too often, because usually when I prescribe it, people can't get it. Or if it is covered, it's like a $60 copay that they just don't want to pay for. So a lot of people are kind of anti-nasal spray anyway, so I usually don't go there unless they just absolutely can't do the gum or the lozenge, and then we might give it a try, see if it'll go through insurance. But I have found a lot of insurance or pharmacies have trouble even like getting it in and things like that. So do you guys have much experience with the nasal spray? Oh, you haven't? Nicotrol. So it is prescribed. It's not over the counter. And there used to be a Nicotrol inhaler that had a little plastic applicator. And that's not made anymore, I guess, because of the plastic applicator. So I don't know if it's ever going to come back, because that was helpful in certain situations, especially for the vapors. The biggest thing with smoking cessation besides medication treatment is behavior change. They have to have a go-to plan. They have to have a lifestyle change. And so a lot of what I do is really, I would say 10 to 20%, pharmacologic management, and then it's 80% counseling, behavior change. How are you going to make this change in your life? They've been doing it since they were teenagers, so they have no idea, really. And so you just have to kind of give them ideas, be mindful of why they're smoking, try not to smoke mindlessly or out of habit, really look at their emotions when they reach for a cigarette. Why are they doing it? Are they mad? Can they do something else to distract themselves? Use a lozenge or gum and try to just distract their mind, go for a walk, call a friend, something. So we kind of go through these 4 Ds. When they think about smoking, try to do something else, delay the cigarette, by doing something else or using their nicotine replacement, drink water and deep breathe to maybe try to get some of that dopamine to release. Cognitive changes are important. They have to believe it. They have to see themselves as non-smokers. I I tell them to be vocal about it. Tell your friends and family you're working on quitting. Some of them don't want to right away because they don't want to be a failure again. So just kind of, I really try to boost their confidence as much as I can. Tell them to kind of see themselves as non-smokers. Some people, especially those that enjoy smoking, I tell them you're probably going to go through a little bit of a grieving process when you're working on quitting. Really just kind of realizing that smoking is part of your past. They're going to be sad about it. They might be mad about it, but they're going to get through it if they really want to quit. We kind of work on, grieving their old way of life, but looking forward to their new way of life. So when we work on a plan, we implement a plan. I give them a 2-week follow-up appointment usually, and sometimes I'll do those in person, sometimes telehealth, sometimes phone calls. It depends on what they want. If it's hard for them to get to clinic, I'm happy to do a telehealth. My telephone follow-ups with patients aren't super successful. I think if somebody says, yeah, you can call me, I kind of know, yeah, this isn't going to go real well. I think that accountability of coming back is really good, or to just be accountable to a telehealth. And then sometimes at those visits, usually it's like very telling if they were successful, if they reached their goal, if they dropped from a pack to a half a pack, they're well on their way. And then we talk about what went well, what didn't go well, and then we kind of modify the plan moving forward. I have them set a goal for each visit. I tell them, it's when somebody's a pack-a-day smoker, it's pretty easy to trim off the first 10. But the last 10's really hard, and the last 5's even harder. So usually I'll tell them, like, your favorite cigarette of the day is going to be the last one to go, because then you're going to be more confident and you're going to be able to say goodbye to that one. But let's just not focus on the first one in the morning. Let's focus on all the others in the day and kind of get through those first. And then, by the time they're ready to give up that last one, they're ready for it. And some people just shock me how quickly they'll quit. And then other people surprise me at how long it takes. So, everybody's different on how they do. Once they quit, it depends on where they're at that point with their Chantix, their nicotine replacement, how much they're using at that point. I usually continue Chantix for another month after they've quit, just to be sure that a lot of those cravings and things are kind of behind them, if they're tolerating it. If they're not tolerating it, obviously we're not going to continue it that long. Or I'll try reducing the dose and kind of see. Nicotine replacement, oftentimes it's sort of already declared itself by that point, how that's going or how it's working for them. If they're still using like maximum patch, we may try to reduce it or step it down, but I usually go by how much craving they're still having and how much gum or lozenge they're using. If they tell me that they're still on a 21 and they're not using any lozenge in their day, I'm like, well, let's drop it and see how you do. To the 14, a lot of people will notice a little pickup in their cravings, but they're kind of able to get through it at that point because they've already worked through a lot of it. Some people have already quit the patch and they're just using the gum or the lozenges for cravings. Go ahead.
What's the average length of time?
That's a really good question. On Chantix? I would say average, if they're tolerating it, in my group of patients is probably up to about 90 days. Sometimes shorter, sometimes longer. But that's about average. And I'd say my average length of time at helping people quit when they really want to is about 4 weeks. And we can get them quit. Sometimes shorter, sometimes longer. I've been working with the same person now for 6 months. So, sometimes you're just never sure they're ever really going to quit, but, we just do what we can do. One thing too, and you guys, this would be valuable for you guys to know, because people may come in and ask about these things. When people are reducing their smoking, and I usually like to tell people that, let's say they decide to quit cold turkey. Well, they're obviously going to have some withdrawal symptoms. Those withdrawal symptoms, even if they quit cold turkey, are going to be the worst in the first 72 hours. And then they're going to start to get better. So when people are quitting and we're giving them nicotine replacement, they really shouldn't have withdrawal. So when they're on nicotine replacement, they can quit quickly, and we're going to be protecting them from some of those withdrawal symptoms. Are they going to have some cravings? Sure they are. But those cravings, are going to be short-lived. So some of the true withdrawal, like agitation, angry, irritability, things like that, those really should be getting less and less as each day passes and they're smoking less. So you can kind of reassure them there too. What you're feeling now isn't going to be there forever. It's just kind of your initial, this is a huge change for your body. It's a huge change for you. But that's why we use the nicotine replacement to help ease that, because the more withdrawal they have, the more they're going to want to smoke. So.
For those that are triggered by, you mentioned like people can be off for a while, but for those that are triggered by life events, is there mental health support for those?
Very good question. So it kind of depends on their situation, how much mental health background they've had in their history. But yes, I start talking to them right away on day one. If it comes down to you're smoking because you're anxious, if you're smoking because you're stressed, if you're smoking, because of those things, could we plug you in with somebody? Because they're probably going to need some more ongoing counseling that, my role kind of ends at this point. So, and then I also will communicate with their primary care and just let them know, hey, they've kind of plateaued. I think they're still smoking mainly because of an anxiety disorder as opposed to true, withdrawals. Is there something we can do different for their anxiety? So I've had a really good luck with primary cares working with me. Within, I don't know how many are from here, but within the med center, the Nebraska Family Medicine Medical Homes, there are kind of just a new behavioral health-led, counselor-led group sessions for smoking cessation that are just kind of getting off the ground. So I'm happy for that, because sometimes people that come in, they don't respond well to one-on-one. Maybe they do want to hear about other people's, goods and bads and things with their smoking cessation journey. So I'm happy that that's another option, but I think at this point they have to be part of that practice in order to refer them. So, but it may open up more down the road, but I think it's good to have definitely them plugged in somewhere if those are the cases. Now, sometimes people don't have that mental health background, but they just have always gone to a cigarette when those bad things happen or they're stressed or whatever. So then it's just talking them through those things. I usually tell people just real simple, when you smoke, your stress is still there. If you smoke, that person is still sick. That smoking didn't take it away. So just kind of processing through what could they do instead, because they don't want to, go back there. They've already worked this hard, So if we can kind of help them there, that's why I talked to them about it on day one. And then also just explaining to people that relapses are pretty common. If it occurs, I tell them, sometimes people have had relapses. I've had patients where they've smoked, like they were quit. They smoked like 2 packs on a weekend, and then they were really upset with themselves, and they call. It's like, you just get right back on your plan. A relapse can happen. And it's just, how can you do better next time? Try not to let themselves dwell in what they did wrong, but rather look at all the good you've done all these weeks. You had one bad thing happen. So, okay, you're just going to move forward from it now. Don't let that one relapse set them back. And usually when people relapse, it's like, oh, I had one cigarette, It's like, okay, forget about it. We're just moving on. We're moving on now. We're not going to change your quit date, based on one cigarette. We're just going to keep moving forward. And it happened, you're going to learn from it. And then what can we do different next time? So it's basically kind of how I go. So unfortunately, I'd like to try to change this in our program, but national statistics on smokers who quit and stay quit at 1 year is only about 20%. So we're trying to boost that statistic within Nebraska medicine. So I think follow-up phone calls would be ideal. We're kind of working on a plan for that now. Offering treatment if relapses occur. You know, once somebody quits, I usually follow up with them for as long as they want me to. Sometimes it's a month, sometimes it's 2 or 3 months, sometimes it's 6 months, depending on what they want. Usually they'll be like, I'll call you if I need you again, you know, and I feel pretty hopeful about that. But yeah, this is an unfortunate statistic that I don't like, but you know, we just keep moving forward and try to do the best we can.
I have a question for
Yeah.
during the height of COVID, when more people were at home and trying to adjust to what were the things that were happening, did you find that many of your patients relapsed from that?
Oh, yeah.
Because of the world phenomenon?
Oh, yeah. Oh, yeah. COVID really caused more people to smoke. I wasn't working here then, but yeah, I know that that's true. I mean, when I worked in my pulmonary clinic, yeah, it was stressful. They were home, they were bored, they were, you know, this or that, they were scared. Yeah. Now, if they had COVID and had a respiratory problem, you know, they oftentimes were able to quit, but yeah. Well, thanks, you guys. We'll see you in the morning.